Welcome to the online staff development opportunity on the topic of ADD and ADHD. My name is Elise Greenaway and I am a social worker here with Pleasanton Unified School District. This course has been designed for you to learn about a common diagnosis that we see here in students quite often. I hope that this online format is going to make learning really convenient for you. You will see that each module has quiz questions that are embedded as you go along, and you won't be able to continue watching the video until you've completed the quiz question. Please note that progress cannot be saved mid-module, so feel free to complete this course at your own pace, but keep in mind that you need to finish a module in order for your progress to be saved. I want to start off by sharing a few statistics to get started. 11%. This is a number that we need to know because the CDC reports that approximately 11% of children and teens ages 4 to 17, that's about 6.4 million children, have ever been diagnosed with ADHD, according to a parent report from 2011 to 2012. 2.3 million youth have ADHD, so that's about 1 out of every 10 kids. So this means that in your class of about 30 students, you probably have at least 3 students with ADHD. While symptoms range for children with ADD and ADHD, the core indicators are inattention and impulsivity, with hyperactivity as an additional core issue in ADHD. These diagnoses are on a continuum, so people have different levels of symptoms and functioning as a result. So for example, you can be sad and not have depression, you can have trouble with attention but not necessarily have ADHD. It's important to understand the difference between ADD and ADHD because people often get them confused or they make blanket statements and don't understand that there's a difference between the two. So while students with ADD are less energetic, students with ADHD are going to be more hyperactive. Students with ADD are less impulsive, while students with ADHD are going to be more impulsive. Students with ADD are going to be somewhat introverted, while students with ADHD are going to be more energetic. Students with ADD are less likely to talk in class, whereas you'll find your ADHD students are really talkative. Students with ADD are going to be the daydreamers that are really thoughtful. ADHD are those kids that are super outgoing. ADD is slower processing, whereas ADHD, the issue is that they're talking and acting before they're thinking. And then ADD students tend to be, like I said earlier, like the daydreamer, kind of socially distant, head in the clouds, whereas ADHD students are typically more class clowns. And then with ADD, they have difficulty making decisions, and with ADHD, you see more of them missing social cues. This is the official diagnostic criteria for ADD and ADHD. So the first component that we want to talk about is inattention. So in order for a student to be diagnosed with ADD or ADHD, they need to have 6 or more symptoms of inattention if they're a child under the age of 16, or 5 or more for adolescents that are 17 and older and adults. Symptoms of inattention have to have been present for at least 6 months, and they have to be inappropriate for the student's developmental level. So the first one would be often fails to give close attention to details or makes careless mistakes in schoolwork, at work, or with other activities. The second one is often has trouble holding attention on tasks or play activities. Often does not seem to listen when spoken to directly. Often does not follow through on instructions and fails to finish schoolwork, chores, or duties in the workplace. Often has trouble organizing tasks and activities. Often avoids dislikes or is reluctant to do tasks that require mental effort over a long period of time, such as schoolwork or homework. Often loses things necessary for tasks and activities, so school materials, pencils, keys, paperwork, eyeglasses, phones. Often gets easily distracted and is often forgetful in daily activities. The other aspect that we want to pay attention to when diagnosing ADD or ADHD is the hyperactivity and impulsivity. So 6 or more symptoms of hyperactivity, impulsivity for children up to age 16, or 5 or more for adolescents 17 and older and adults. The symptoms of the hyperactivity, impulsivity have to have been present for at least 6 months to an extent that is disruptive and inappropriate for the person's developmental level. So Some of these might be often fidgets with or taps hands or feet or squirms in their seat. Often leaves seat in situation when remaining seated is expected. Often runs about or climbs in situations where it is not appropriate. Often unable to play or take part in leisure activities quietly. Is often on the go, acting as if they're driven by a motor. Often talks excessively. Often blurts out an answer before a question has been completed. Often has trouble waiting his or her turn. And often interrupts or intrudes on others. So, for example, they might be butting into conversation or games. In addition to this, the following criteria needs to be true for ADD or ADHD. The first is that several symptoms were present before age 12. The symptoms need to be present in 2 or more settings, so at home and at school, or at home and at daycare. Clear evidence that symptoms interfere with daily functioning. And lastly, symptoms don't happen during the course of schizophrenia or another psychotic disorder, and symptoms are not better explained by another disorder. There are 3 different presentations of ADD and ADHD, and because symptoms can change over time, the presentation can also change over time. So for predominantly inattentive presentation, this is if they have enough symptoms of inattention but not hyperactivity or impulsivity that were present for the past 6 months. Combined presentation is if they have enough symptoms of both criteria for inattention and hyperactivity, impulsivity that were present for the past 6 months. And then predominantly hyperactive presentation is if there's enough symptoms of hyperactivity, impulsivity, but not inattention were present for the past 6 months. Let's take some time to shed some light on the common myths that often come up with ADD and ADHD. This is a pretty common diagnosis, but we often make a lot of mistakes because it is so common. So while it was previously thought that ADD and ADHD showed a higher prevalence in boys, recent research actually indicates that the number of ADHD symptoms is highly similar between genders. Some research indicates that girls are less likely to demonstrate hyperactivity and aggression and are more likely to show strong challenges with inattention and internalize their symptoms. When keeping our radar out for girls, we want to look for the daydreamers that are just struggling with executive functioning in the areas of like organization and getting started on and finishing work. Girls with ADD and ADHD are 5 times more likely to struggle with depression, and potentially due to the fact that they internalize criticism and are more likely to engage in self-blame and shame. Girls that have ADD or ADHD are also 3.6 times more likely to have an eating disorder, maybe as a way that they're trying to exert control in their lives. And during puberty, boys' symptoms tend to improve while girls' symptoms actually worsen. And in one study, mental health clinicians miss the diagnosis of ADD and ADHD for girls 50% of the time, just because it doesn't always look like how we imagine ADHD to look. The next myth is that students with ADD or ADHD will not be successful in school or life. We know this is not true, and while these children are likely to experience a range of academic challenges, there is a large and growing number of successful entrepreneurs, actors, artists, and business people that have reported having this diagnosis. So we know that with the proper support and understanding of their needs, teachers and families can create and maintain the support systems needed for these children to find success. The next myth is that only young children have ADD and ADHD and they will eventually grow out of it. So the main symptoms of ADHD, inattention, impulsivity, and sometimes hyperactivity are the same for teens as they are for children. However, you may notice some differences. For example, you may struggle less with symptoms of hyperactivity such as fidgeting or staying seated than you did when you were younger, if you have either of these diagnoses. As adults, hyperactivity is often replaced with restlessness. On the other hand, you may notice greater challenges with staying on top of your schoolwork and other responsibilities. This often happens because there are more demands on your time and schoolwork is probably more difficult and there's higher expectations for you to be independent now that you're a teenager. Another thing associated with ADHD in adolescence is difficulty with executive functioning, which is the brain's ability to prioritize and manage thoughts and actions. In other words, executive function allows you to think about goals and consequences for your actions, plan accordingly, evaluate your progress, and shift plans as necessary. When you're a child, your parents and your teachers may have taken care of some of the executive function chores by reminding you to do your assignments, nagging you about organizing your schoolwork, letting you know about upcoming appointments. However, in adolescence, your parents and your teachers are expecting you to start doing these things yourself, and sometimes that transition can be tough on you and those around you. We often don't know adults we interact with have ADD or ADHD because they found jobs that are compatible, have learned skills, and they're on medication. The next myth is that if a student is able to play video games for hours, they can't possibly have ADD or ADHD. I hear this a lot of staff pushing back to parents and saying, I don't think this student really needs a 504 for ADD or ADHD because I know they play video games for hours. Well, there are less dopamine receptors and transporters in the nucleus accumbens, which is the reward center of the brain. So doing things that are not of interest to them, it's going to be a lot harder to stay engaged with. So it is possible for students to not be attentive at all at school, but if they have something that catches their attention, they are capable of paying attention to that subject for long periods of time. The next myth is that students who have ADD or ADHD can't possibly also be classified as gifted. So be aware that ADHD and giftedness can coexist. According to the federal guidelines, gifted and talented students with disabilities are described as students who give evidence of high achievement capability in areas such as intellectual, creative, artistic, or leadership capacity, or in specific academic fields, and who need services or activities not ordinarily provided by the school in order to fully develop these capabilities. So, higher intellectual ability may actually mask ADHD, leading to a delayed diagnosis. However, high IQ is not enough to be successful in school. The final myth we're going to cover is that only experienced teachers can diagnose ADD or ADHD in students. The truth is that teachers cannot be the sole diagnoser, and there's no actual test for ADHD or ADD. It's really important to talk about behaviors that you're seeing rather than making a diagnosis. Teachers should keep their eyes peeled as they're often the first ones to notice that a student may have these symptoms, but they need to refer to a mental or medical professional for an ongoing diagnosis. So when a mental health professional or a doctor is making an official diagnosis of ADD or ADHD, there's not a specific test that they do, but they do look over these following things. They look for the DSM diagnostic criteria, which we talked about earlier. They look at childhood or family history from the parents. They look at a description of school performance, which would come from you as teachers. They're looking at school report cards, classroom observations, official school records, and then they administer like a variety of tests such as intellectual, academic achievement, behavior rating scales, executive function rating scales, and then lastly, a physical exam to rule out other disorders. So as you can see, there's no quick test that we can take or give a student to determine if they have ADD or ADHD. It's a diagnostic process that's going to require the input of a lot of people that have eyes on the student, teachers included. It's really important to remember that ADD or ADHD is a brain-based disorder, and the symptoms shown in ADHD are linked to many specific brain areas. So you can see a picture here of a brain without ADHD and a brain with ADHD. There's just different things going off in the brain of someone that has ADHD. When people say that this is a made-up diagnosis to give students an excuse to not pay attention, this picture can be really helpful to show people. It's essentially a typical brain map pattern seen in a student with ADHD, and it shows an underactive red color frontal lobe. ADD or ADHD is a complex neurobiological disorder where a few structures of the brain are smaller and their neurotransmitters, the chemical messengers of their brain, are not working properly, and that's specifically the norepinephrine and the dopamine. We're going to talk a little bit more later about how medication can help with this. There's no single cause for ADD or ADHD, but these are some of the contributing factors that we know of. Research has clearly shown that the majority of cases of ADHD have a genetic component. So over 50% of children with a diagnosis have at least one parent that has it too, and 30% of them have siblings that have it. There's other causal factors as well. Many of these happen during pregnancy, complications, so low birth weight, prenatal maternal smoking, other prenatal complications that can come up can be causes of ADHD. And then injury to the brain is something that we know can cause ADHD, so head trauma, stroke, brain tumor or disease, and then exposure to lead or other toxic chemicals. It's important to note that patterns of parenting and family interaction may help reduce the impact of the symptoms of ADHD, or they might make them worse. However, parenting styles do not cause ADHD. And although some people say that it can be caused by too much sugar or watching too much TV, research does not actually back up either of these claims. Co-occurring disorders are something we want to be aware of when it comes to diagnosing ADD or ADHD. The iceberg analogy can be really helpful with this because it points out that only the tip of the problem is visible. So behavior problems are often noticed first, but there's typically much more happening under the surface. Only 1/8 of an iceberg is actually visible. Research shows us that 2/3 of students with ADHD have at least one other condition. So for example, these might include oppositional defiance disorder, conduct disorder, depression, anxiety, substance use, learning disabilities, or sleep disturbances. These are just some of the things that students might be battling as well. One of the most commonly confused diagnoses with ADHD is PTSD, post-traumatic stress disorder, because so many of the symptoms are the same. I have a visual here of the diagnostic criteria for PTSD and ADHD, and I have the overlap in yellow. So both have difficulty concentrating and learning in school, easily distracted, often doesn't seem to listen, disorganization, hyperactive, restless, and difficulty sleeping. So as you can see, there's a lot of things that overlap, and it makes sense that people would be confused. So it's really important to make sure that when we're screening for ADD or ADHD, we also keep in mind that we want to screen for PTSD. The executive functions are a set of processes that all have to do with managing oneself and one's resources in order to achieve a goal. It's an umbrella term for the neurologically based skills that are involved in mental control and self-regulation. So unfortunately, when it comes to ADD and ADHD, executive functioning is often impacted. And so I have 11 ways listed here that we see some of this impact. The first is response inhibition, so stopping behaviors at appropriate times can be challenging. Flexibility, so moving between situations and responding with flexibility to situations can be hard. Number 3, emotional control, so the ability to apply rational thought to emotions. Number 4, task initiation, so beginning a task and then independently being able to generate ideas and responses and keep going. Number 5, working memory, so holding on to information in order to complete a related activity. So listening to a lesson and then doing an assignment that coincides with it after. Number 6, planning and organization, so organizing and keeping up with one's own work. Number 7, organizational materials, so organizing physical spaces and materials, so keeping an organized backpack, keeping your schoolwork in check. Number 8, self-monitoring, the ability to recognize how one's performance at a task measures against standards and expectations. Number 9, sustained attention like we talked about earlier. Number 10, time management, because often people with ADD or ADHD have a different sense of time and how much time different tasks are going to take. And then lastly, number 11 is metacognition, so awareness and understanding of one's own thought process. When we look at behavioral manifestations of ADD or ADHD, this is really important to keep in mind. So a student that has ADD or ADHD, like we talked about in the last slide with executive functioning, they have difficulty recalling the past. So they're not studying their past actions, which leads them to not learn from past behaviors, and then they act without a sense of hindsight and they repeat the misbehavior. This is why we see a lot of students with ADD and ADHD getting suspended or having behavioral issues with the same things over and over. It is a challenge for them to examine their own behavior and change their behavior and see how it impacts others, and then see another person's perspective. So what does ADD or ADHD look like in the classroom? These are just some of the things that we know. Difficulty planning projects or writing papers, difficulty understanding and planning appropriate amounts of time to complete tasks and assignments, difficulty communicating details, so either verbal or written, of stories and ideas, difficulty memorizing or recalling facts and information when needed, difficulty beginning on tasks or activities and coming up with their own ideas, needing more time to formulate an answer to a verbal or written question, following directions, multitasking, remembering to-do lists, and difficulty recalling information even as it is in use. So losing track while answering a question or forgetting information during a test that they could recall easily in a class discussion. As we mentioned earlier, there are some challenges specific to teenagers that we want to make you aware of. The more complex the ADHD, the greater the risk for a multitude of problems. So that can include learning disabilities, failing a grade, skipping a grade, suspensions, expulsions, and dropping out of school. Key areas of the brain are maturing 3 to 4 years slower in people with ADD or ADHD than in children without attention deficits. This is a huge discrepancy. It can also be easier to miss a diagnosis since the hyperactive impulsive characteristics are more common in younger children and might not still be present in teenagers. On average, households of teens with ADHD have a higher level of parent-teen conflict than households with teens who do not have ADHD. One source of conflict in the home is that teens want more freedom and independence. However, the difficulties with organization and forgetfulness and thinking before acting that commonly go along with ADHD might make parents more reluctant to give their kids the freedom that they want. In addition, a lot of teens with ADHD have more difficulty completing homework and chores on time or following through with rules due to inattention, distractibility, lack of interest, or lack of organization. These difficulties can lead to a frustrating cycle of negative interactions for both the teens and the parents because the parents feel like they need to lecture, yell, or punish, and teens are responding with anger or in other ways that aren't very helpful. So there's more conflict at home. When it comes to driving, drivers with ADHD have more tickets because they're involved in more accidents because they make more impulsive errors and they have a slower and more variable reaction time. The use of stimulant medications when prescribed has been found to have a really positive effect on driving performance, so that's something to keep in mind. Another challenge specific to adolescents is adherence to medication. So nearly half of children don't take their medications as prescribed, and the use of ADHD medications decreases over the teenage years. This decrease occurs for a lot of reasons. So one might be that teens have negative attitudes towards medication use. They could feel like their ADHD symptoms are not impairing their functioning. They might dislike the side effects of the medication, or they might simply want to take a vacation from their medication to see what happens. Teenagers are curious. When we talk about emotional functioning, the teenage years tend to be a really emotional roller coaster for all kids, but those with ADHD are prone to have poor emotional regulation. And so this is going to make it a lot higher highs and lower lows. Their emotional impulsivity can make it especially difficult for them to cope with frustration, and it can be tough on them and the people that are around them. Students with ADD and ADHD are also more likely to engage in risky behavior. So research shows that teenagers with ADHD tend to start using cigarettes, alcohol, and drugs earlier and are more impulsive with their use. And then lastly, social challenges of, not being able to keep things in order. This can impact relationships. Symptoms of ADD and ADHD can vary based on several factors. So we talked about gender earlier, the type of ADHD, the environment that the student is in, other strengths they might have, and other impairments like we talked about with co-occurring disorders earlier. There is no current cure for ADD or ADHD, but there are 4 things that research shows are very effective. So the first is education, and we have behavioral therapy, medication, and exercise. We're going to get into each of these things. There's a lot of alternatives such as elimination diets, nutritional supplements, and play therapy, but these all lack scientific research to show their effectiveness as ADHD treatments. So when we talk about education, education is a necessary component to any treatment, and it provides teens and families with the tools to understand their disorder and their treatment. However, education alone is not a sufficient treatment. So we want parents and students to understand the diagnosis, understand what it entails, but then in addition, we want to be addressing it in other ways. When we talk about behavior therapy for treating ADD or ADHD, there are proven psychosocial treatments that include parent-teen training in problem solving and communication skills, parent training in behavioral management methods, and teacher training in classroom management. Behavior modification is the only non-medical treatment for ADHD that has a large scientific evidence base. Behavior modification is often put in terms of ABCs. So there's the antecedent, things that set off or happen before a behavior. The behavior, so the things that the child does that the parents and teachers want to change. And then the consequences, so things that happen after behavior. So in behavioral programs, adults are learning to change the antecedents, for example, how they give commands to children, and the consequences, for example, how they react when a child disobeys or doesn't obey a command, in order to change the child's behavior, which is the child's response to the command. So by consistently changing the ways that they respond to children's behaviors, adults teach the children new ways of behaving. So parent, teacher, and child interventions should be carried out at the same time in order to get the best results. Another research-based way to address ADD or ADHD is through medication. Research shows it is effective for 75 to 92% of students. Unfortunately, only 32% of people with ADHD are actually taking medication. So although medication is highly debated among many families, on children with ADD or ADHD, the research shows that it's very effective. It doesn't cure ADHD, but when it's effective, it eases ADHD symptoms during the time it's active. So it's not like an antibiotic that might cure a bacterial infection, but it's more like eyeglasses that help to improve the vision only during the time the eyeglasses are actually worn. So many medications prescribed for ADD or ADHD are stimulants that are intended to increase levels of dopamine and norepinephrine in the brain. These are the two chemicals that are important for us for attention and focus. It's really important to understand that dosages for these medications have to be controlled and monitored because an excess of dopamine and norepinephrine can put stress on the brain, and this is what is going to cause students to feel worse, and it actually ends up exacerbating the ADD or the ADHD symptoms and behaviors. Research suggests that for individuals with ADD and ADHD, there's more than an 80% chance that they're going to respond to the medication in a positive way. Stimulants are short-acting, so they're only effective when they're being taken regularly, and they stop working if they're not taken. So these types of medications have a long history of use in individuals with ADD and ADHD, and they have shown to be a safe and effective treatment method. Each person that's considering medication treatment for ADHD should first have a really careful, comprehensive assessment to clarify the diagnosis, identify any other medical, psychological, or learning problems that might be present with the ADHD, and learn about what ADHD actually is. And then after the diagnosis has been made, a treatment plan should be developed in consultation with the physician or other medical professional. And then it's very key that the medication is monitored, very closely monitored and observed to see how effective it is. There's a lot of common myths and concerns specifically about medication that I want to pause real quick to address because these come up so often. The first is that medication becomes less effective in the teen years. This is not true. In fact, medications for ADHD should be as effective, but patterns of co-occurring conditions may require changes to the treatment regimen. And additionally, many teens may benefit from changing to a longer-acting medication to provide better symptom management throughout the day, because a lot of teenagers have activities after the school day and into the evening hours. Another myth is that medication use may increase the risk of substance abuse. And in fact, as mentioned above, medication reduces the risk of substance abuse for teens with ADHD because they won't need to self-medicate. It's going to help them focus. It's going to help them deal with their symptoms, and so they're not going to turn to marijuana to help them focus. And then lastly, people talk all the time about medications being unsafe. There's been a ton of research done on the safety of medications used in people with ADD or ADHD, and they have not suggested any significant negative side effects. Psychostimulants are the most commonly used ADHD medication, and despite their name, these medications do not work by increasing stimulation of the person. Instead, they help important networks of nerve cells in the brain to communicate more effectively with each other. The effects of psychostimulant medications are usually noticeable within 30 to 60 minutes once an appropriate dose for that individual has been found. However, determining the proper dosage and medication schedule for each individual often takes several weeks, which can be discouraging for families at first because we always want a quick solution. Non-stimulant medications often require several weeks before their full effects can be observed. Between 70 to 80% of children with ADHD respond positively to these medications, and in some instances, the first medicine they try might not be the right one, or perhaps a higher dose might be needed. Short-acting preparations generally last for about 4 hours, and then long-acting preparations are more variable in duration, so they might be more like 6 to 8 hours or 10 to 12. And of course, there can be wide individual variation that can't be predicted and will only become evident once the medication is tried. It's really key to identify the specific dose and timing of medication for each individual. There's no consistent relationship between height, age, and clinical response to a medication. So a medication trial is often used to determine the most beneficial dosage. So the trial usually begins with a low dose, and it's gradually increased at 3 to 7 day intervals until clinical benefits are achieved. And it's common for the dosage to be raised several times during that trial. In addition, we want to make sure the individual is monitored both on and off the medication. So for children, observations are collected from parents and teachers, coaches, tutors, anyone that is watching them on a regular basis, and then from there we can tailor to what the student seems to need. Potential side effects are important to note. Most immediate side effects related to these medications are mild and they're typically short-term. The most common side effects are reduced appetite and difficulty sleeping. Some children do experience stimulant rebound, so a brief period of negative mood, fatigue, or increased activity when the medication is wearing off. And these side effects are usually managed by changing the dose and scheduling for short-acting medications or by changing to a prolonged release formulation. Headaches and stomach aches can also occur sometimes, but these usually disappear with time or, if necessary, if you reduce the dose. And some children may have an initial slight effect on height and weight gain, but studies suggest that ultimate weight and height are rarely affected. Tics are involuntary motor movements like eye blinking, facial twitching, shrugging, and throat clearing, and sometimes children who are given stimulant medication may appear to develop tics. The medication, however, does not actually cause the tics, but may instead bring them to notice earlier or make them more prominent than they would be without the medication. Tics usually go away naturally even while the individual is still on the medication. When meds are working, teachers should see the following changes. So increased attention and concentration, compliance, effort on tasks, amount and accuracy of schoolwork produced. They should see decreased activity levels, impulsivity, negative behaviors and social interactions, physical and verbal hostility, and then overall improvement in working memory and self-talk, verbal fluency, ability to organize thinking, handwriting, motor coordination, self-esteem, emotional control, acceptance by and interaction with peers, and awareness of the game in sports. So as you can see, there can potentially be a lot of benefits from finding the right medication and finding the right dosage for a student. Some reasons that medication may not be effective is if a student is on the wrong medication, maybe their dose is too low, student forgot their medication. This is common, and so we have something where parents can sign a permission slip that their student can be given the medication while at school. So for those kids that typically forget to take their medication, the parent supplies with their medication and sign off on it. The health assistant can administer the medication during the school day just in case they forget. Maybe the medication hasn't kicked in, maybe it's worn off, they've developed tolerance to it and need to increase the dosage or switch it up a little. Or, like we talked about earlier, there could be untreated coexisting problems. So we might be treating a student for ADHD and giving them ADHD medication when really they have post-traumatic stress disorder, and that's why the medication is not working. So it's very helpful for teachers to provide feedback for parents on how effective the medication is, because there's checklists that can be found online as far as medication effectiveness, school ratings, and this can be really helpful feedback for parents and doctors. The last way that we can address ADD or ADHD in a holistic sense is through exercise. We know that exercise optimizes learning by increasing the neurotransmitters dopamine, serotonin, norepinephrine, and neurotrophins. And although it's not as significant of a difference as medication, research shows that exercise greatly improves learning, memory, executive skills, and the growth of the new brain cells. For the last part of this module, we want to talk about how we can specifically support students in the classroom. This includes 3 components: accommodation, instruction, and intervention. When we talk about accommodation, we're referring to what you can do to make the learning easier for students with ADD or ADHD. So, some of these include seat them up front. If you employ a seating chart in your classroom, endeavor to seat the student that's closer to you or near the front of the room to help keep them on task throughout the lesson. This is also going to help you to notice when they appear confused or off task. You can also create a quiet area that's free of distractions for test taking and quiet study. You can give instructions one at a time and repeat as necessary. If possible, work on the most difficult material early in the day when their brains are still fresh. Use as many visuals as possible, so charts, pictures, color coding. Help students create outlines for note-taking that organizes the information as you're delivering it. Create worksheets and tests with fewer items. Give frequent short quizzes rather than long tests and reduce the number of timed tests. Test students with ADHD in the way they do best, such as orally or filling in blanks. As part of an accommodation, you could accept late work and give partial credit for partial work. Establish priorities, so students with ADD or ADHD might not recognize which students should take priority over others, so you could establish a color-coded system with a student in which you highlight assignments with various colors to indicate priority level. Minimizing distractions, so attempting to limit the distracting situations that occur in the classroom. So just ensuring that things like lighting and temperatures are consistent where possible, and seat the student with ADD or ADHD away from high traffic areas such as the classroom door near the pencil sharpener. Working with them on time management. So this is often a significant challenge for teens with ADD or ADHD, and so you can support them in the classroom by using task timers and making verbal announcements that indicate when they should be switching to a different task. Breaking up long tasks into shorter ones. Encouraging peer support, so there's a lot of research on peer mentoring. Employing cooperative learning. Teaching note-taking strategies, which we'll get to some examples in a second. Help them make a game plan for big projects, so help them, again, breaking big things up into smaller steps, and then the use of planners, which we'll also talk about. An example of one of the accommodations I mentioned, note-taking strategies. This is an example of one of these such strategies. So Broil, so encouraging students to write down anything the teacher writes on the board, anything the teacher repeats, anything the teacher mentions that will be on the test, anything the teacher says is important, and anything that's in the list. Another accommodation is using a planner. So this is an incredibly helpful tool, but just handing the student a planner and encouraging them to use it is not going to be enough. we need to sit down with them and teach them how to actually use this planner to their advantage. So ask the student about some time management challenges that they've been facing and discuss together how the planner could potentially benefit them. You can really maintain, their motivation through positive reinforcement. So praising the student every time they're using their planner, frequently point out instances where using the planner helped them to get their work done. And, in dire situations, bribery is not out of the question. So giving students some kind of reward for every time they follow their planner routine can really help build something into a long-term habit. And to make a planner truly useful to a teen who thrives on creativity, you've got to sync it up with their processing style. So there's no single system that's going to work for everyone, and it's important that you work with this student to test different approaches. So if you need ideas, the following planner strategies have proven successful for many students who are right brain dominant. So using tons of colors and making the planner visually appealing. Personalized language, so, don't allow handwriting difficulties or distractions to derail you from your child's, from the student's efforts. Help them come up with easy shorthand or symbols that they use for test day or worksheet due, something like that. And then routines. If using a planner feels unnatural to a go with the flow student, begin by establishing the structure of a daily routine. So set up a time every day for them to review and update the planner right before they start working on their homework, right when they get home from school, something like that. And parents can be engaged in this. It would be helpful for parents to get involved with the routine of checking the organizer and be that additional accountability. And then lastly, help them include more than school. Help them put sports practices in there. Help them put other things in there so that so they bake it into their everyday life, not just academic life. When it comes to instruction, there are several things that you can do when starting a lesson, conducting a lesson, and ending a lesson that can specifically support students with ADD or ADHD. So when starting a lesson, using sound to start a lesson can be really helpful. This can be like an egg timer, a cowbell, or a horn. You can use subsequent cues to show how much time remains in a lesson. Establishing eye contact is super important. Listing activities on the board and being explicit with instructions and the materials needed can be really helpful. When conducting a lesson, keeping pace and presentation can be really helpful. So, including variety so students don't get bored and restless. Keeping instructions simple and structured, including different kinds of activities, really mixing it up, using visual cues, allowing frequent breaks, being aware of asking a student to perform publicly. This can be really challenging for a lot of students with ADD or ADHD. And then as you're ending a lesson, summarizing key points, having students repeat the assignment in unison to just verbalize it back to you, and then be specific about what they should be taking home. When it comes to intervention, there's several things that we can be doing to support students. So try to ignore mildly inappropriate behavior if it's unintentional and it's not distracting other students or disrupting the lessons. Work out a couple of warning signs with a student that has ADD or ADHD. So this could be a hand signal, an unobtrusive shoulder squeeze, a sticky note on the student's desk. And if you have to discuss the student's behavior, make sure that that's done in private. Reward efforts and time on task. So regularly praise the student when they're on task and doing well to highlight these behaviors. Ensure clear boundaries, expectations, and reward systems. So be consistent when enforcing rules. You really want to make sure that if you're asking for a certain behavior in one setting, you're also asking for it in another. Act quickly when you're giving a consequence so that there's a real connection made between the actions and the results, and it's really clear. Seat the student near another student who can serve as a positive role model. Reprimand behavior privately if possible. Pick battles and avoid power struggles when at all possible. So avoid inviting confrontation with the student on every minor misbehavior. We need to remember that many of these will not necessarily be intentional, so lost homework, talking during instruction. We just want to reinforce and praise other students who do not respond to the misbehaviors. Be careful not to sound accusatory, so criticizing behavior. So you want to make sure that you criticize the behavior and not the student, so they're not going to feel blamed and they're less likely to get defensive. And then lastly, check-in, check-out is a great resource. This is a PBIS intervention where a student develops goals with a staff person at school, not necessarily their teacher. It could be anyone. It could be a custodian. It could be someone in the front office. It could be another teacher that they enjoy being around, but this person checks in and checks out with them each day for goal monitoring progress. Teacher and support staff involvement in IEPs and 504s is super important. Want to encourage you, when you're participating in these, come prepared. Know what the student's academic and behavioral strengths and areas for growth are, and really emphasize those words, strengths and areas of growth, rather than deficiencies and issues that they have. We want to make sure to be really mindful of executive functioning and how it's impacting both academics and behavior, because we know that when academic issues are dealt with effectively, we often see behavioral issues reduced. You can come to the meeting and suggest accommodations. I highly encourage you to look back on these slides, think through, like, what are some accommodations that I feel like would be reasonable for my teaching setting that I feel like I can follow through with, and recommend those in the meeting to be added to the IEP or the 504. Speak to the effectiveness of medication from your observation. So like we talked about earlier, you are getting the front row seat to see how effective these medications are, and you can offer really valuable feedback to the parents, the student, and the doctor. And then lastly, examine study habits. So think through, what are they already doing and how can I support them in improving their study habits? When we talk about measuring medication effectiveness, this is just one example of a rating scale that can be found online. So this is something to you could maybe print out and fill out before coming to 504 or an IEP, just to help you reflect on what you're observing with the student, because it's hard to just abstractly think, how is this medication working for the student? Like, sometimes it seems good, but sometimes it doesn't. So really working through these questions, and then you can bring this paper to the meeting and just share, my professional opinion, like, this is what I'm seeing, and I just think it could be helpful to share with the doctor what I'm seeing in the classroom setting. When we talk about helping students with their study habits, this can be a helpful worksheet for you to use with students as well. So asking them to put a check next to the things that work best for them. So helping them think through, like, when are they studying? Who are they with? Where are they doing it? What are the conditions? What helps them learn and remember stuff? How do they stay organized? When do they need breaks? These are all great questions to go through with a student, because just asking a student, what do you need to help you study better? Like, they're not going to be able to answer that right off the bat. They are going to need some prompts to think through it. Addressing behavior through shaping can be a really helpful strategy. So we have to address academics first, like I mentioned before, and then if it's still an issue, behavior. So an example of behavioral interventions would be that you address the academic first, address academic challenges first. You start at the student's present level of functioning, then you break the skill down into segments, you begin teaching the new skill, and then you learn to recognize improvement and acknowledge it. An example of shaping would be you choose a beginning point. So the beginning point is that no homework is being completed, and the target behavior achieved that you're wanting to achieve is that the student completes homework. So level 1 would be parents get the student started on homework. Level 2 would be that parents get students started and then they monitor and check completed work. Level 3 is that parents remind the student to start, drop in, and prompt only once or twice, and they check completed work. Level 4 would be that the parents set a timer, the student starts by themselves, the parents then check the completed work. Level 5 would be that the student sets a timer, starts and finishes the homework by themselves, and then parents check the completed work. And then level 6 would be that no monitoring is needed from the parents. And so the target behavior would be achieved of the student completing homework independently. As we end this module, I really want to emphasize that it's important that we recognize the strengths in students with ADD and ADHD. The desirability of specific behavior changes over time, and characteristics that are not valued in school might really be valued in the adult work world. There's another video module that you'll see on here about ADHD being a superpower that's really fascinating. So I want to encourage you to discuss the strengths that you see with your student and see if they have others to add. This can be a great way to engage your students. So if we look at a change in perspective, bossiness can be seen as leadership. Hyperactivity can be seen as energetic. Strong will can be viewed as tenacious. A daydreamer can be seen as creative. Lazy can be considered laid back. An instigator can be an initiator. Someone who questions authority can be independent. Someone who's argumentative can be persuasive. Someone that's aggressive can be known as assertive. And someone that's manipulative can be considered savvy. You've now completed the first module of this online series on ADD and ADHD. The next couple pages are just references in case you want to do any additional research based on the information on these slides. You can now continue on to the next module.